So question about recurrent mitral regurgitation for patients who have had prior MitraClip therapy. We've seen a couple cases for us. You had a case. I'm curious, and for Paul and others, when you decide about going back to do another second attempt, 2, 3, 4 years later, if you're thinking about putting a clip or if you're thinking about putting a plug, how does the gradient at the end of the initial index case play into your decision making? And if your gradient is nearing 4 or 5, would you attempt to put another clip or a plug?
That's a very good question. I mean, a lot of the cases today was, how to deal with that dilemma. And I'm not sure there's a right and wrong answer, but I think the most important thing is just try to spend the time, look at the echo, and see why we have recurrent mitral regurgitation. What went wrong? Did the clips move? Do we have pathology that has progressed between the time the case was done and now? Is there something else? Does the annulus continue to dilate? And why mitral regurgitation happen? I think there is a lot more report coming out about plugs. A lot of people use plugs. I think between plugs and clips is how the vast majority of them have been treated, especially when they're very close to the commissure. Bolt presented a case yesterday where he lacerated leaflets and did a TMVR in a patient. But I don't think that this is, especially with the current era of TMVR, I don't think this is going to be done routinely, at least in the next couple of years.
You know, we pretty much had, I think, 3 talks on AR for the most part. And so maybe Mac and Paul for sure, and I see Alan is in the audience. Alan and I have talked about treating AR in VAD patients. I know you've had a couple patients, we've had a couple patients. So Mac, 20% oversize, is that all you need? You just need a 20% oversize? Or do you look at the CT to get a sense for where else, say, the evolute might have some contact with the aorta, or is it just all about the annulus? Yeah, sorry, I put you in a bad spot. Maybe come up, or... Yeah, you can sit down.
Yeah, so I think that's a great question. What should we be using, since all we have are devices right now that anchor on the annulus, except for that nice case that Scott just showed using the J valve. But really the core valve is designed to anchor on the annulus, so that's why that's primarily what I rely on. Even though it enlarges as it goes up into the ascending aorta, I don't know that we can really rely on that to be anchoring it. But even with 20% or more oversizing, there's still a rate of migration into the ventricle in the core valves. So we need to recognize up front that there will be some patients that need a second valve. And in those cases, we've found that balloon expandable with additional volume, 29S3, is effective to rescue those patients. So that's at least our approach.
Yeah, that's good.
Well, great. I'd like to close out this session, and I'd like to announce also that there's going to be a lunch symposium with a live case, and that's next door with Dr. David Rizek. Please see if you could attend that lunch symposium. Thank you very much.